Hello and welcome to the European Respiratory Journal podcast. My name is James Chalmers and I'm the chief editor of the European Respiratory Journal. And we're talking cystic fibrosis on this month's podcast. And I'm delighted to be joined by our associate editor for CF at the ERJ and professor at Charité Berlin, Marcus Moll. Welcome, Marcus.
Good afternoon, James.
So we've got lots of exciting research to talk about in CF. We're seeing a revolution in the field of cystic fibrosis. So starting off, can I ask you, tell us a bit about the upcoming European CF Society conference and the role that the ERJ is going to be playing there?
Yeah, sure. And, first of all, thank you for the opportunity to discuss some of the recent, progress and papers on CF published in the journal. And I think this year we are joining for the third time a journal session that was originally organized by the Journal of Cystic Fibrosis as a society journal and the Lancet Respiratory Medicine. And we were invited some years ago by the ECFS to join that session based on the quality of CF work published in the ERJ. So this year, we will feature a recently published study from the French Compassionate Use Program that interestingly studied the clinical effects on the most recent CFTR triple combination modulator therapy, elexacaftor, tezacaftor, and ivacaftor, in patients with severe lung disease that do not carry the common F508del allele and are therefore so far not eligible for this therapy in Europe.
Okay, so let's talk about that paper, which is a really exciting paper. So this you tell us, Marcus. So the French Compassionate Program was providing the modulators to those individuals who currently in Europe are not eligible for access to those treatments. But how did they determine which patients would or would not benefit from those medications?
Yeah, I agree. That's a really interesting study. And, just to provide a little bit of background. So this triple combination therapy was developed to repair the folding and trafficking defect of the common F508del mutation. Now, in vitro studies in cell lines expressing other mutations, it was found that it can also have beneficial effects and correct some of the other missense mutations that are associated with mistrafficking. Now, in the US, the FDA was actually open to take these data to approve the therapy for an additional 177 rare CFTR mutations, whereas the EMA so far has relied only on limited it to patients with at least one F508del allele that were included in clinical trials. So the approach of the French group was to hypothesize that there may be patients that are responsive because they have rare mutations of unknown functional consequences. So therefore, they are actually pretty unusual and so far. A novel approach was just to treat all patients without an F508del allele. So what they found was, number one, patients with nonsense mutations that do not produce CFTR protein did not respond, which is sort of confirming to what we know about CF and the pharmacology. And these were about 50% of their cohort. Out of the other 50%, the other 50% responded to the triple combination therapy. And when they looked at the genotypes, they found about half of them had FDA-approved mutations. So that was also an important confirmation of previous in vitro studies. But interestingly, they identified another half, the other half of this group responded to this novel therapy clinically, which was determined by clinical response in terms of improvement in lung function, as well as improvement in sweat chloride as a biomarker of CFTR function, which was determined by a board of experts after 4 to 6 weeks of intervention.
Yeah, so this is very exciting. So people who wouldn't otherwise have had access to these treatments benefiting, as you say, in terms of lung function and sweat chloride. Let's assume that now many of these patients will receive modulator therapy. I mean, what's the potential impact of this paper? What percentage or number of patients are we thinking might be able to benefit?
Yeah, I mean, with the with the US approval, we at the moment think we are just above 90% of eligibility. And if this, based on the results of this paper, if this gets a broader attention and approval as an approach, this could lead to, probably close to 95% of eligibility based on the genotype. Yeah, so it sounds small, but it's obviously a huge advance for these patients, with ultra rare mutations, where it would never be possible to do a traditional clinical trial.
Yeah, and I think that's a key thing. This is an observational study, but this is in a group of patients with rare mutations where you could never possibly do a placebo-controlled study. What do you think is the future of this, Marcus? Because this study won't have been able to capture every rare mutation, so there will still be many mutations out there where we don't know what the response is. Is the way this study was done the way to do it? Test it in a patient and see, or are there potentially in vitro approaches that could be used?
Yeah, absolutely. So I think it's a very interesting approach to do it this way. But there were some patients where the clinical experts were struggling with making the call. So I think in the future there may be opportunities to combine this with in vitro testing, not in cell lines, but in patient-derived cell models that have been developed over the past years, including rectal organoids, as well as primary nasal epithelial cells that allow to study CFTR function in individual, in cells from individual patients. And I think combining these two approaches will really, lead us the way to further enhance precision medicine for CF and make sure every patient who's responsive to these therapies will actually become eligible.
So this is a very exciting paper. It's online in the May issue of the European Respiratory Journal. So everyone listening, please go and give that paper a read.
And if you're attending the European CF conference, you're welcome and invited to step by in the journal session. And I'm really looking forward to the discussion of the data in that forum.
Yeah, so please do go along to that session. It's great for the European Respiratory Journal to have that profile in CF. But this paper is not the only exciting paper coming up in CF in the journal. We've had it's a really exciting scientific time for CF. So we have a lot of very high quality papers coming through. Do you want to give us a taster of what else is coming soon to the journal, Marcus?
Yes, so I totally agree. It's a really exciting time, not only for clinical, but also for translational research, because we have now the opportunity to, in investigator-initiated observational studies, to look at the consequences of CFTR dysfunction or, improving CFTR dysfunction in these patients in the real-world setting. There is a couple of actually back-to-back papers we have recently published in the ERJ, interestingly, not on epithelial cell function, the airway epithelium that we typically focus on in CF research, but on macrophage function. And it's long been known that CFTR is expressed in macrophages and that it plays an important role in both phagocytosis, but then also intracellular killing of bacteria. And so what these two studies independently did is that they again studied the effects of initiation of this triple combination therapy on macrophage function and asked the question if this correlates with the clinical response. And they could very nicely show that ETI restores CFTR function in macrophages and that improves bacterial killing, including killing of Pseudomonas, and that these improvements are associated with clinical improvements. So I think this is very interesting work because it's sort of out of our usual focus, and because it could also have important therapeutic implications in the future. If telling us that we should probably more think about the macrophage as an important innate immune cell, important for lung defense, also as a therapeutic target.
It's very exciting. I mean, the triple combination allows us to figure out in humans what the CFTR does beyond the epithelium, because whereas we can study things in, for example, knockout animals, they're not always relevant to humans. Whereas here we have actually a human system where you have a profound change in CFTR function, allowing really impressive delineation of the function of this protein in different human tissues. I suspect we're going to see a lot more of this sort of work, Marcus, in different organ systems, exploring the role of CFTR.
Yes, that's one hot topic in the future when as we can treat the lung better, the extrapulmonary manifestations, but we still also have to understand better what's going on in the lung with this CFTR modulator therapy. And therefore, happy that another paper will soon be published in the journal where I was involved in a study, an interdisciplinary study, and we performed here in Berlin, where we really took a multimodal approach, if you want, to look at the downstream consequences of CFTR function, including mucus rheology, because the mucus is highly viscoelastic in CF patients, but also changes of the microbiome and inflammation and the proteome of the sputum. And, these studies in my mind are important because we can learn how much we can achieve with restoration of CFTR function in established lung disease, but they are also informative with regards to the question how many additional therapies will be necessary. So key findings of this study were that ETI therapy rapidly improves mucus rheology, the microbiome composition, including relative and absolute load of Pseudomonas. It reduces inflammation, including protease activity. However, there's still in all outcome measures substantial residual abnormalities or changes. We were able to include a healthy control, and by comparison to the healthy control, I would say the residual changes in these patients were at least in the range of other chronic airway diseases such as non-CF bronchiectasis.
Okay, so that's, I think, a really, really important study, actually with therapeutic implications, because there's a lot of question at the moment on the sputum rheology side of whether we should be stopping mucoactive drugs, and on the antibiotic side, whether some patients still require their inhaled antibiotics. So based on your data, what do you think the answer to those questions is going to be?
Yeah. So, just to have it clear, these were adult patients with chronic lung disease. They had an average FEV1 in the 50s, 60s, but in this patient population, we found residual mucus dysfunction based on the rheology. We found that although the Pseudomonas load was reduced, most of the patients that were chronically infected with Pseudomonas before retained their chronic infection, and there was still free protease activity, both of neutrophil elastase as well as the other neutrophil serine proteases. So my prediction would be, because we know that these factors are key risk factors for lung disease progression, my prediction would be that this patient group will still benefit from more effective mucolytics, more effective anti-inflammatory / anti-protease therapies that are currently developed for bronchiectasis, for example, as well as novel approaches, more effective anti-infective approaches, such as phage therapy that I think is a very exciting new approach to target the chronic Pseudomonas infection.
So this is a really important paper, isn't it? Because you hear people talking about CF being a problem that's solved, and it's clear from this data and from other data that particularly for the adults with established lung disease, there's going to be an ongoing need for additional treatments long term. So that leads me quite nicely to the last question, Marcus, which is really to ask you to gaze into your crystal ball and tell us what is the future for CF.
So that is a real crystal ball question, James. Yeah. So, I would probably start saying that it will be important that we do the same studies, both on the basic defect as well as the downstream consequences in the lung now in children that can be treated earlier. So we know from functional measurements that the current CFTR modulator therapy restores about 40 to 50% of CFTR function. So a key question will be, is that already good enough to sort of long-term prevent irreversible damage of the lung? So that will be a key question because it will tell us if it is probably important to further enhance functional correction in children to prevent the onset of lung disease if we can start early. And then a big focus at the moment is obviously on the patient that cannot benefit from CFTR modulators. So these are the plus minus 10% of genetically ineligible patients. And there's a real focus at the moment or revival, if you want, on gene therapy with improved technologies, from ranging from making more stable RNA for RNA replacement therapy that could be done by inhalation, as well as development of less immunogenic viral vectors, such as adeno-associated virus that are non-integrating, but also developments in lentiviral vectors that could potentially integrate into the genome for long-term correction. And then obviously, ultimately, also gene editing with CRISPR-Cas-based technologies that, if successful, could really be used to obtain a cure of a patient's individual mutation that would then really, not only be a therapy, but also a cure. So I think that is very interesting, but it's also early times. It would obviously be great to see some of this work also coming to the journal.
Very exciting. We've seen a revolution in CF, and it sounds like there's more revolutions to come. A really exciting area of translational science and patients really benefiting from these really effective therapies. Thank you, Marcus. That has been a really nice summary of all of the action that's going on in the journal around cystic fibrosis, and a reminder for those attending the European CF conference to go along to the journal session and see those really exciting data presented. This has been the European Respiratory Journal podcast. My thanks to Marcus Mall for making this such an exciting discussion, and we'll be back next month discussing more exciting new respiratory science. See you all soon.